everyone. Welcome to another live guest interview within Mindful Journey. If this is your first time joining us, thank you so much for being here. We're so delighted to have you. And if you've been with us for a number of these guest interviews, well, welcome back. And thanks for continuing to take time out of your days to be with us. As always, we strive to align ourselves with guests who we believe will not only be able to share some unique insights relative to their expertise and profession and what it is that they do so exceptionally well, but also with individuals that we believe will be willing to impart upon you all a few words of hope and inspiration as we strive to get just incrementally better. Our guest today certainly is no exception, Dr. Drew Pate. Although he and I have not formally met, the first time we connected, it became glaringly obvious that he has a heart and desire to serve and help people. That's not just through his role as the chair of Department of Psychiatry at LifeBridge Health, which is a 5-hospital healthcare system in Baltimore, Maryland, but also just through the conversation that he and I had about social media and a variety of things that he has seen as a contributing factor to perhaps some of the challenges that we all as humans may face in this day and age as it relates to our mental health. Many of you have probably seen his formal bio, so I'm not going to belabor it. I've already mentioned that he is the chair of psychiatry, the Department of Psychiatry, pardon me, at LifeBridge Health. He received his medical degree from Louisiana State University, School of Medicine, and got his completed his fellowship, pardon me, in conjunction with Harvard Medical School and the Children's Hospital in Boston, Massachusetts. He has served on a variety of boards and again is deeply devoted to helping people. He served in a capacity before where he was actually treating patients and serving patients, but today is more in a leadership position within LifeBridge. So with all that being said, it's my pleasure to introduce you all to Dr. Drew Pate. And Dr. Pate, thank you for being here with us today.
Thanks, Adam. I appreciate that for those kind words, and it's great to be here.
Thank you. Could you give us just an overview for those listening in who may not be familiar with LifeBridge Health? One, what is LifeBridge Health? And two, what is your particular function within the organization?
So LifeBridge Health is, as you said, a system of 5, medically and surgically oriented hospitals in the greater Baltimore area. And at each of those hospitals, there is a significant behavioral health substance use treatment component. And as the Department of Psychiatry is responsible for all those behavioral health and substance use treatment services across the system, I'm the chair of the Department of Psychiatry, which means the clinical functions of those roles are ultimately my responsibility. So we have a range of adult and child services across the system, including hospitalization services, day treatment services, opioid treatment program services, emergency room services. So we sort of pretty much provide the entire continuum of care, with a couple of inner city hospitals and then a couple that are in more suburban areas in the greater Baltimore area. Sinai Hospital is our flagship hospital, which is the largest non-academic hospital in Maryland. At University of Maryland and Johns Hopkins are also here in Baltimore. Their hospital systems, and those are the only two which are larger than us. So we're pretty a substantial footprint when it comes to reaching out into the community and involving ourselves in many of the neighborhoods in Baltimore and the surrounding area.
That's wonderful to hear. It sounds like there's some element of potential collaboration there because you are, one of the larger ones. Is that accurate and fair to say you and Johns Hopkins and University of Maryland do some collaboration, or is it a maybe competitive nature where you're not able to?
Yeah, and so it's interesting. So Sinai Hospital is sort of a partial teaching hospital. So we're not a full traditional university hospital where every department has training. But we at Sinai have traditionally partnered with other academic centers around, particularly Hopkins in the past, to work on some training programs and some other initiatives around medical student and resident training. However, our recent venture into that is a little different. We've actually partnered recently with George Washington School of Medicine, which is in Washington, D.C., and we will are opening over the next couple of years a campus on the site of Sinai for medical students to do their third and fourth year, which in medical school is your 2 clinical years. The first 2 years are primarily focused on textbook, classroom, laboratory-based, learning. The last 2 years are when you do sort of your supervised clinical work prior to going off to become an intern or a resident. And so we'll be doing that in our department. Because psychiatry is what's called a core component of medical education. So it's one that every medical student has to have in the country, along with surgery, medicine, pediatrics, and a couple of other things. We will be a big component of that. So it's a nice component for our future to have. Anytime you have students and people who are wanting to learn, right, it enriches all of us. It makes us all think. It makes us all more aware. So I think that will be a really nice benefit to the work we do and the people we care for.
Yeah, that's so great to hear. Well, I'm excited to hear how that initiative continues to progress in the future, and wonderful to hear that there is some collaboration, because oftentimes, the world of business and medicine inherently is business to some extent. Sometimes there's a competition that disallows collaboration. So it sounds like if that's existed in the past, maybe going forward, it's not going to be as much so. So that's great.
Yeah, I think I'm a big believer in being driven by our mission, right? Which is, as you say, and I believe it's unfortunate that much of the business mindset has entered healthcare, and I think it has done a lot of damage, to healthcare and to patient care. However, those of us who are in the clinical world need to really stay focused on the work we do and being our sort of compassionate day-to-day selves of caring for all those who come to our door, regardless of their need. And to me, if we stray from that mission, then we stray from the reasons we should be showing up to work every day.
Powerful statement, certainly. What drove you, Dr. Pate? Because I think people listening now can probably understand how passionate you are just from that brief context you provided. What drove you personally to get into medicine? What was the inspiration that got you into medicine, and more specifically psychiatry?
Yeah, it's interesting. So, I come from a family where my brother and I were the first generation to attend college, right? So my parents were very focused on the importance of education, but neither of them had the opportunity to pursue any education beyond high school. And so we were always raised and with a certain respect for those who had achieved a significant amount of education. And as sort of a working class kid in Louisiana, the primary person, frankly, we came in contact with was our doctors, right, who had education, and there was sort of some esteem to, I loved my pediatrician, still the one doctor I probably have seen more than anyone else in the world, right, who was this older gentleman, Dr. Anderson. And I also, to make myself sound like a big nerd, but I loved school. Like I always loved studying. I loved learning. I loved learning about new things. And my parents did their best to, take us around to different parts of the country growing up and camping and seeing, what we could. And so we were always raised with kind of an inquisitive mindset. And so my brother, who's also a physician and actually a radiologist, he was the first to sort of decide to pursue a path to medicine, and it really just aligned nicely with my interest in science and and understanding and knowledge and education that was accessible to me. And so I followed in his footsteps, which were nice because he was always an excellent student. So people had a good sort of mindset toward me as soon as I showed, oh, you're his brother. I'm like, oh yeah, that's it. But anyway. So we did that, and then once I got into medical school, which is a very rigorous, academic experience after college, right? I realized that all the procedure-based things, which is a lot of medicine, the things where you are, doing things to people, the surgically oriented fields, really left out the human experience in my view, and so. As I got exposed more to the psychiatry component and, the opportunity to really know your patients, to really understand their worlds, to appreciate the social context of what was going on, to have kind of a broader impact on their future generations than just a one-time visit or just, kind of blood pressure maintenance check, the other things that, were the bread and butter of medicine. I really was drawn to it. And and I'm a child psychiatrist, right, as you mentioned, and by training. So in psychiatry, you have to do adult training first, and then you move on to 2 more years of additional training to become a
Hmm.
child psychiatrist. And I was always, if I would have gone into a traditional medical field, it definitely would have been in pediatrics. Also, I enjoy kids more. I enjoy working with families more. Their vibrancy, their forward, orientation.
Hmm.
They're pushing, toward development and becoming, different people all the time is just, very rewarding to me. So most of my clinical work over the last, I finished medical school 30 years ago this year. Most of my clinical work over that time has been with kids. And
Hmm.
so even though I'm trained and certified in both adult and child work, I gravitate towards seeing kids. And so that's, which I find very rewarding.
Yeah. Well, it's so nice to hear your heart for it because I think like you mentioned, I love it. You mentioned the mission piece, Dr. Pate, because whatever any of us do, whether we're in psychiatry, whether we're working as a school teacher, whether working as a firefighter, whatever the job function is, if we're not deeply committed and mission driven, it's easy to burn out in that space or just
Right.
go through the motions where you're not deeply and compassionately serving. So it's so nice to hear from you that there was a why, if you will, behind driving you into psychiatry. Given your expertise, if you will, in both sides, in adolescent and in adult psychiatry, I'm kind of curious because I've always been intrigued this, and I don't have the research you probably do, which is why I'm asking you the question as to whether or not mental illness is something that folks are born with in terms of their brain's physiology, or if it can be brought on by a series of life events that are potentially negative, i.e., divorce or bankruptcy, etc. Is it something we're predestined for, or is it something that could occur as a series of those things, or somewhere in between?
So it's, as you said, it really, the way we think about it currently, right, it is somewhere in between that. It really is both, right? So we all are born with a certain genetic propensity for lots of things, right? For athletic ability, for cognitive ability, for obesity, for addiction, for mental illness, for physical illness, high blood pressure, diabetes. Everything, is within our DNA to some level, right? And some people have more of a propensity based on their DNA and their genetics than others for certain things. But that propensity for any illness has to be combined with the environmental exposure, right? And the one thing that we have known about mental illness and psychiatric illness since the 1960s and 70s, when a guy named Dr. Rutter in England did what were called the Isle of Wight studies, and these have been replicated in different ways, was that childhood adversity is directly associated with the development of mental illness and medical illness as an adult. And you can actually quantify the number and 1+1. So if you had in specific childhood adversities like exposure to domestic violence, community violence, substance use in the family, a parent with significant mental illness, sexual, or physical abuse, other traumatic experiences, you can actually quantify the number of those with the increasing chance that you will develop other psychiatric and medical illnesses, which is also
Mm,
quite interesting, right? So, and it's a multiplicative issue, not an additive one, meaning so 1+1 does not equal 2. So if you have two of these adversity events, they're not 2, it's more like 3 or 4. So they kind of pile
mm,
on to each other. So the more you have, your chance of developing a serious illness are dramatically increased. So people who have significant adversity in childhood, especially in those first few years, like the most important years of childhood are probably from birth till about 3, that you end up with a great chance of obesity, a great chance of developing chronic obstructive pulmonary disease, a great chance of being addicted to cigarettes, a chance of
mm,
developing depression and anxiety, that is much higher than those who are not exposed to adversity. So what I tell
mm,
people always, Adam, is we know the answer to many of the problems in healthcare, right? But we sort of turn our back on them, because the answers aren't in caring for people when they present, when they're ill. The answers are caring for people from the time they enter this world until they
Mm,
start school, basically, right? Because we know if we care for our communities, our environment, we decrease violence, we decrease domestic abuse, we decrease sexual abuse and exposure, then we change the course of people's lives over the next
yeah.
decades. And um, so there is that direct correlation. But at the same time, here's the tricky thing, right? Those same people who have a high chance of developing all those issues and illnesses based on their early adversity will sometimes have tremendous horrible things happen to them, but they will go on to be very successful adults, right? So there's a
Mm,
certain resiliency that's also in our genetics
yeah,
that we know.
sure.
And then you see the opposite of the person who had nothing happened to them adverse, right? They were safe, secure, well, safe communities, stable family lives, stable caregivers. Then, but to grow up to have very serious, psychiatric, illness that was a powerful genetic component in their system, is the way we think about it. So it's not 100% predictable, but
Mhm.
that we know where certain sort of groups are likely to fall and where we could intervene. I sort of
Mm,
use also the example of Vietnam veterans, right? The post-traumatic stress disorder, which we've known about for since World War One. It was called shell shock back then, right? We know that's another good example of this. Like some folks have a genetic propensity to develop these post-traumatic symptoms.
mhm.
And when you look at the Vietnam population, the Vietnam veterans, which was probably the most traumatic war experience that many people have had in the 20th century, all of the veterans who were exposed to the same conditions, about 35% of them developed PTSD from that experience. But of those out of who were exposed to the same events, 65% did not, right? So it means that
Mm,
so even though there was a much higher chance of those developing, because of the horrible traumas and exposures they saw, there are also a decent number of people who didn't. So it's not like, oh, these things will always make you develop PTSD.
mhm.
There's clearly something about each of us as an individual that affects that outcome.
Well, that's quite interesting. I wrote down shell shock. I hadn't heard that before, and it's certainly it resonates. Although I have zero military experience, we think about that in society as the one area where folks end up coming back facing some form of mental illness.
Hmm.
And to hear those statistics, it's interesting, and it makes me think how how can we get people how can we get people to want to change? In other words, if they're coming back and they are dealing with the PTSD effects but are suppressing it, how do we reach them? And then also, how do we reach the people who may not be suffering from PTSD but suffering from other things and unwilling to confront it? So I guess
Right.
I gave you a lot there, but I'd like to and I know there's not a one size fits all approach. You have to do certain evaluations and can prescribe medicines, et cetera. But from your vantage point and from your years of experience, what's maybe one or two things that we can do to actually get people to want to change? Because if they know they're suffering yet are not confronting the things, like what is it that's going to get them to do it? I don't know if there's a one answer or not, but love
No,
to
it's tough. It's hard because there really is an answer, and the installation for the desire of change is a very difficult one to give someone externally, right? There's the old joke about how many psychiatrists it takes to change a light bulb.
I
Only,
have not
have
heard
you ever heard that? It's only one, but the light bulb has to really want to change, right? And so, and so I mean, that's so part of that is that dad joke is real actually underlying the point that um I can't make you want to change. What I can do is offer you the opportunity, right, to
it.
change. We use one of the metaphors I use a lot with folks, especially because I was trained in more of a kind of traditional therapeutic style of working with folks, is the work we do that I do is really what I call kind of the holder of the light, right? The holder of the flashlight. Like we're on a path together. all I can do is use the flashlight to point out where to go next or what looks like a safe place to go or a good place to go. But I can't make you go there, right? You're going, you're leading the path, on that when we're together. And I can sort of illuminate, oh, this is a good place to go. This is a good thing to try, especially when it comes to these kinds of issues, because the commitment that we have to have as individuals to change really is one that does have to come from inside for the most part. There are times when we can impose change on people. For example, the court system, right? I mean, if you're placed into one of the drug courts or one of those opportunities because of a substance use issue, and we know that imposed change for those issues can sometimes be very helpful. Because people are being held accountable for their behavior, right? It's like, we're going to test your urine, we're going to check in with you, we're going to make sure, that can actually be quite successful. The kind of change for more less behavioral things, for lack of a better word, and more kind of cognitive experiential things is difficult to come up with. But I think part of what we want to do is motivate people to see that there is help, right? That there is the opportunity. There is almost nothing in mental health that we actually don't have good, well-proven treatments for, like PTSD, for example, depression, anxiety, serious psychotic illnesses. But we need to, one, make sure our community is well-trained in those tools and that we know how to use the right kinds of treatments. And two, we present those tools to the folks we're caring for to make sure they know, listen, there's a way to expand the way you're dealing with this. One of the evidence-based treatments for people with suicidal thoughts is called dialectical behavior therapy, a very powerful and amazing treatment that also requires a very high level of intensity and commitment, right? But the first step in that, first step in engaging in that treatment, because it's really focused on people who have kind of more ongoing suicidal thoughts and behaviors, is that they have to commit to staying alive, right? That they have to make that commitment that we are going to work on this and that you're not going to try to end your life so that we can do this treatment. So I think it's really incumbent on us as people who care for those with psychiatric and mental health issues to make sure that we present what the options are and use our abilities to motivate people to engage in them and to not let them off the hook, right? That's how to make sure that they're showing back up, that they're engaging, get their family, get their support systems engaged. And it has to be the right time. It's not always the right time for the person. I may meet you today and give you and you're like, no, I can't, I can't do that. So you have to get to a point in your life where you feel like things need to be different and things need to change. And that's different for everyone. For some people, that means a relationship that broke up. It means, they're not being successful at a job. It means their parenting struggle, whatever it is. Yeah. Something will motivate all of us ultimately. So we just have to always be there for people when they're ready to take that next step.
Yes. What can we do from a societal standpoint, and then maybe if you feel comfortable talking on a leadership standpoint, if we think organizationally, creating safe spaces and such for people to not necessarily want to change. I already asked you that question, but to come to grips with the fact that it's okay to not be okay. Because I feel like there are people who have these suicidal ideations who never seek treatment. And my estimation is a lot of that comes back to stigma, that I'm not going to speak up because I'm going to be perceived as less than, that my colleagues are going to think I'm inadequate or I'm a failure. So, like, what do you think, Dr. Pate, from a society perspective, we can start there, and maybe organizationally, if you want to talk leadership, to create spaces where people feel that it's okay to not be okay? Because I think right now we don't do a good enough job of that collectively across the board.
Yeah, no, you're exactly right. We do not. But the good news on that is that we're getting better, I think, at that from the stigma is still tremendous and overwhelming. And it's also, in some ways, it seems to me, and I don't think there are any good studies on this, but it seems to me it's also somewhat generational, right? So the younger generation, and I've been doing this a long time, but the generation of those, under 30 or so these days, and even younger people, adolescents, teens, seem to be much more accepting and open about discussing, mental health issues and available and willing to talk about it right among each other. And I think that's been one of the positive things. A lot of, some of the social media and some of the, celebrity types who've struggled with issues have been open about it, which allows, I think, that generation to be a little more accepting. So I think we're moving in some ways in the right direction. But we also know that the rates of suicide have gone up dramatically in the last 20 years, right? And it's skewed younger and younger because of so many other stresses in society. So it's really important, I think, that we make sure that those of us who, and the other point I want to add to is you're absolutely correct. The majority of people who actually who die by suicide have received no mental health treatment, none. Now, almost all of them have been to their primary care physician or primary care provider recently. So part of, again, what we have to do as a society, I believe, is have that accessibility always there for individuals who are going to be struggling. We've seen an increase in accessibility this last year with the introduction of the 988
Yes.
number.
Yeah.
So we've actually had a dramatic increase in calls to that number nationally versus the old 800 number. But I've always been a fan. I wish there was a way to do this better of some of what I call kind of more retail psychiatry, right? You see how you have all these urgent care centers and places on almost every corner these days. It would really be nice to have something like that for mental health, right? Where we actually had high quality, not because right now, if you show up at the emergency room, you're going to get evaluated by someone who has some mental health expertise. Usually not a psychiatrist, usually someone else in the mental health world who's licensed and trained and all that stuff. They're really evaluating you for kind of what level of care you need. I feel like it'd be kind of nice if we had a model where you could actually step into like evidence-based high quality treatment right off the street, right? And we know that those who practice the treatments that we know work are actually the least accessible to most people, because there's a smaller number of folks who provide them, and the people who provide them fill up very quickly because people want to see them. So our system is sort of broken. I think from an organizational standpoint, it kind of goes back to what we said at the beginning. We have to focus more on our mission and less on the money, because there's the way healthcare is paid for in this country, which is, just bizarre, frankly, but mental health in particular is extremely discriminated against when it comes to payment models and authorizations, and there's so many barriers. And I feel like organizations really have to, I think, be more aggressive in pushing back on that, and also understanding that to provide this service, we need to have more of a community orientation and figure out the financial piece later on, because that's frankly one of the big impediments. People don't want to provide a lot of psychiatric services because hospitals can make $1 zillion on surgeries or oncology, but they're going to lose money if they provide good mental health services. Wow.
That's saddening to hear, especially when so many organizations, and we can probably, rattle off 10 or 15 of them right off the top of our heads, who promote these, ideologies internally that are people-centric. I heard it phrased to me once before that this was actually from a guy who retired from Marriott, and he believed that they were actually living what they preached. He said they would always sit around the table talking about budgets reflect priorities. He said if we're serious about our people being the most important thing of our business, important part of our business, we've got to put our money where our mouth is, so to speak.
Right.
Yet there are so many organizations. I mean, just hearing it from you, the barriers that there may be. I could imagine employers may not want to offer psychiatric benefit because it's going to be more costly to their bottom line, perhaps, if the hospitals aren't profiting quite as much, because a hospital is probably going to pass off that cost. Or am I mistaken here? Am I misunderstanding? Is that fair to say? Is a hospital passing off some of the cost maybe to the employer, to the insurance carrier, I guess, because they're wanting to, increase their margins.
Right. Yeah. Yeah. No, they're wanting to, hospitals in an attempt, even nonprofit, right? They have to at least break even. They're wanting to um, provide services that allow them to stay open and provide and pay the staff and pay. It's very expensive, right, to provide hospital-based care. I mean, psychiatric hospital care is probably more expensive in some ways than medical care because you have to have more staff, more direct care workers, more people, observing and monitoring what's going on. And so if there's a disincentive to do that because you can't even break even on that service, then it's a big reason why people don't get into the child psychiatry business a lot. Where there are even fewer child and adolescent services because that's it's a very expensive service to provide if you want to do it in the highest quality, highest standard way. And so instead, we see most people providing, unfortunately, a lower quality, lower standard expectations than any of us would want for our loved ones. And so we have to really, I think, the ultimate solution, I believe, Adam, unfortunately, in my opinion, is that, our healthcare and the way we deliver it in this country has to dramatically change, right? We have to take a more holistic view of where mental health fits in. Because again, we know, and this is well proven, that if an individual has a psychiatric diagnosis, a mental health issue, and they're treated and they go into the hospital for a medical problem like a heart attack or the diabetes flare up and they need to be medically hospitalized, just the presence of having a psychiatric diagnosis increases their costs 2 to 4 times over someone who's admitted with the same medical problem. And so the real place we're spending a lot of money in healthcare on people with mental health issues is on their medical treatment because they're more expensive and it requires more effort to get folks back on track. So if we think about using our mental health resources across the whole system and improving the efficiency across the whole system and the cost effectiveness, then we could be much better off. But our system is not built, unfortunately, for efficiency. It's built to reward specific things at a very high rate and other things not at all, basically.
That's disheartening to hear. I seen a comment come in, and I didn't get a chance to read it all, but I'd like to address it now rather than a back end, if that's okay. And the attendee said, "So well said, Dr. Drew. If we could remove the barrier to entry for these services by making services more accessible to people, people will seek help sooner and more often. Some of my coworkers want to seek therapy due to work stress, but they don't because it's not covered by insurance." So it's kind of what you're alluding to. What might you recommend to a leader who's on this call, perhaps somebody who owns a company of 30 people or a leader who's sitting in the benefits space within their organization, HR folks, because we certainly got some of those within our organizations who are part of Mindful Journey. What would be your recommendation to those individuals to let their people know that they genuinely care? What can they do? What systems can they implement? What programs, what can they do from an insurance perspective to maybe decrease that barrier so folks not only feel more comfortable, but have access to psychiatric care?
Well, I think the first thing that you do, Adam, is understand what they actually offer, right? A lot of places don't even understand what benefits they actually offer. They contract with a group that is supposedly providing or managing the behavioral health, the psychiatry benefits, and they will tell them, oh, we have the full, people can get access to everything through us. But because of those barriers, as your questioner just mentioned, the prior authorization hoops, the things that maybe the HR professional or the leader doesn't understand, they actually don't really have access to those things. So I think one, working with whoever is managing their benefits to make sure they understand, what is the process? Help walk me through the process of understanding how people would access things like outpatient therapy, which should be accessible to everyone, right? And so some organizations, I think, I'm a big believer in the EAP, the employee assistance programs, right? So those at least can get people started. So if you're in a stressful workplace environment, but also, I was consulting with a group recently that their EAP was done by in-house people, meaning the other employees who also worked in mental health within that organization. which I think, there's a problem with that, right? Because people are not going to want to go to someone else they're going to be
Sure.
working with. So if you're thinking about planning a service, you need to make sure that people have immediate access to at least the beginnings of outpatient therapy through what I would say an external organization. And those first 6 or 8 visits are at least covered and complete, right? So you want, and now that we have, medium such as you and I are using here of being able to do telehealth, every organization should be providing, I believe, a connection with a good outpatient therapy experience for all their employees, and it doesn't even have to be in person anymore. And beyond that, so especially like to the work, just let's take the work stress piece, for example. For many folks, we know that, 6 or 8, sessions of working with a good evidence-based therapy who's educating you and increasing the tools in your toolbox to manage stuff is probably going to be enough. So we need to make sure everyone has that kind of foundation, but then there always needs to be the second layer for those who need more and more support. And that is something that many times it does take the leader or the organization to push back directly on their insurer and say, because these insurers, they're the ones who have the money in healthcare, right? It's not really the hospitals, it's not the doctors, it's not the nurses. These big insurance companies tend to profit after they've paid all their bills, $5 to $10 billion a quarter, right? So when you think about that, that's money taken out of the pockets of these employees who want treatment, who want services, and going into the pockets of someone else. And so I think there's no problem with someone being profitable, right? That's the world we live in. But I have a problem with it when you're being exorbitantly profitable, and we hear that people don't have access to the most basic care services. So I do find that individuals who are managing from an organizational standpoint many of these services or the insurance interaction don't really understand what their employees actually have access to. So I think if they understand that and then hold the insurers accountable, that we expect that people will get this much service without any roadblocks, without any headaches right up front. And that's what I tell individuals all the time who are having trouble accessing services is go to your HR team, complain to them because they don't like unhappy employees. People want their employees to be happy. And if you find that I'm providing a service that's actually making my employees unhappy, then they need to hear about it because that's actually sometimes the most powerful intervention you can get to access services.
Good advice. Thank you. Yeah, thanks for elaborating on that question. I'd like to go back to just some of the mental illness that may be prevalent in people's lives. And I had come across a statistic. I don't know if it's accurate or not. I forget where the study was from. This was years ago that I pulled it, and it said between 1990 and 2017, depression had risen by 50% through that time frame. Number one, do you know if that is an accurate assessment? And number two, if so, or if it's roughly in that ballpark, what do you think is contributing to more of a depressed society right now? Why are people struggling with depression more rapidly than they had before?
Yeah, and Adam, I haven't seen the exact numbers on that, but what we do know is that over that time, especially over the last 20 years, we have consistently seen when we do what are called these kind of epidemiological studies, right, where people just kind of go door to door or talk to people or have people do online surveys, we find people are reporting more and more depression and anxiety in particular, and substance use as well, which we can't leave out because, the number of acts of overdoses in this country has gone up dramatically. 100,000 people died of accidental opioid overdoses last year. We had about 20,000 homicides in this country. And so compare that, right, and about 40,000 suicides. And so we do see it increasing. I think that the stresses of modern society and the difficulty with managing many of these stresses where, we've been bombarded with input, over the last 20, 25 years, especially with the introduction the things that we carry around in our hands or purses or pockets every day, which are constantly dinging and dragging us away from being aware of our surroundings, of sort of having a mindful acceptance of day-to-day life. I think really does stress us out in many ways. When I first started this 30 years ago, seeing kids who were before puberty who completed suicide, who died by suicide, was almost never happened. Almost never happened in the country. A handful. This now we're seeing that's the group that is the fastest rising in completing suicide. We're talking about 10 and 11-year-olds. So the social stress, I think, also, there's been, I think, a lot of uncertainty and instability introduced into the Western world in the last couple of decades, where, we've seen a rise in hate crimes. We've seen a rise in, racist attacks and anti-Semitic attacks, and, in our LGBTQ folks who we care for and love are being attacked at an unprecedented rate. And so I think there's been a discord in society that I think is also reflected in this sensation of people feeling as though there may not be hope for their future, which contributes to the depression and anxiety component, because uncertainty and fear, right, drive away our sense of hope, right? They sort of cloud our horizon, around when we're trying to look out on the edge and see what's out there for us. And so that's where we really have to grab that piece and do what we can as individuals about it. But I think those numbers are real, and I think, again, when you look at the numbers of suicides over that same time, the number of overdoses, the number of substance addictions, I mean, it's just it is astonishing that it's sorry for me to say that those numbers have only gotten worse in the time I've been in this business.
Yeah, it is. Yeah, it's certainly some of those numbers you just rattled off are even more disheartening than the 50% that I'd seen be, through those 27 years of the rise in depression, because, suicide, as you mentioned, completing suicide, there's those 40,000, there's no, after that, there's no hope anymore, right? I mean,
Right.
there is nothing that can be done. And I think you said 100,000 people overdosed last year accidentally on opioids. And yeah, that I assume folks revert to opioid in moments of pain and crisis,
Right.
and then they end up getting addicted. So with all that known, Dr. Pate, what is your message to someone today who may be on here dealing with depression, whether clinically diagnosed or not? Because I believe we all face moments of despair and hopelessness, whether
Right.
it's losing a deal in business or breaking up with a spouse, divorce or bankruptcy, et cetera. What's your message to those folks? Like, what's one or two coping mechanisms or strategies they can utilize on their own without seeking formal treatment that can help them find hope on the other side of pain?
I think the big piece for me, Adam, is reminding folks to focus on the possible, right? To focus on what you can actually do about your day. I have some very close friends who are heavily involved in the AA movement. And one of the things that, and so many powerful things I think come out of that movement in particular, and one of the things they've actually taught me, is the incredible focus on just that day. Like, that I may not know what I'm going to do in the next hour, but I know what I'm doing this minute, right? If I know what I'm doing this minute, next minute that rolls around, I know what I'm doing that minute too. And so you're managing and focusing on what you can manage and what you can control in your life on a day-to-day basis, because you can't, frankly, we would all be overwhelmed if we thought about the things that we can't control and the forces that impact us, right? So we think about what can you do every day to make yourself feel happier, to have a better experience in the world. What is it that we know that makes some people sort of sustain themselves? For most of us, it's something that we can do for ourselves every day that doesn't take much time, doesn't take much energy. Is it, sitting down and talking to a friend, having a cup of coffee, reading a good book, taking a walk around the neighborhood, little things that you can do for yourself that separates you from being overwhelmed and accepting the condition you have at that moment, right? Without judging it or thinking about how
Mm,
you want to change it, but just being in that moment. If you find yourself constantly being worried and fearful, you got to find a way to break away from that and focus on what you can do something about, and let your worry time, let it be prescribed. Do worry, in the afternoon for from 4:30 to 4:45 every afternoon,
yeah.
like let that happen. But
Yeah, yeah,
don't
yeah.
don't let it consume you, because the more you get consumed by your fear and your pain, then the further you get away from finding the hopeful possibilities that exist, and reminding yourself there is always help. It may be hard to get to,
Mm.
but there's always a place to turn, whether it's virtually, on the phone, in your primary care doctor's office, to friends, to family. Um, the road never ends, right? There's
Yes.
always the next stop.
Yes. I like how you framed that, Dr. Pate, about this is the first time ever hearing that you're actually recommending perhaps a window where, hey, it's okay to have 15 minutes that you actually maybe even schedule to say, I'm going to
Hmm.
have a little pity party, because we're often taught, especially, I'm going to pick on us guys right now, like, you got to toughen up and
Right.
suck it up, and you can't, don't feel sorry for yourself. But I like that, because I think sometimes going through that process, I know for me, I journaling has been so therapeutic and a
Right.
big part of my life. And when I think about it, journaling in itself, in many regards for me, is a pity party to some
Right.
extent, because it's just kind of releasing all my emotions and thoughts. And then after it's out and I feel what I'm feeling, it's like, okay, now we can move on with the day.
Right.
So yeah, I really like that recommendation. I guess I'm just kind of synthesizing that for listeners and partly for myself, because I've never heard it framed
Yeah. In the
quite like
field, we
that.
call it worry time. Right.
Okay.
You
Yeah.
schedule worry time, and journaling's a good way to do it, because, as you said, it allows you to accept your experience, right? Because that's one of the things, is the title of your show, right? To being mindful is not about, making sure you're comfortable with everything and making sure you're at ease and you're relaxed. It's about accepting the experience as it exists and allowing it
Mm,
to be there, and not
mhm.
fighting it, not trying to change it, but then changing what you can, right? It's like you're doing the best you can, but you can also always be working to be better.
Yes. Yes. Great perspective. Well, if we can, I know our time is running. I promised you we wouldn't surpass an hour, so we've got about 13
Right.
minutes
Yeah.
left, if that's okay. I'd like to transition a little bit to your level of comfort, to your world, and I think I'd shared with you on the front end. One of the questions I've asked of every guest is something relative to them, and the intention of it is to let the listeners in recognize that we all face hardship. Even somebody like yourself, who is the
Right.
healer, right? The treater, the person who prescribes the methodologies or the medications to help people get through, yet you too face difficulties, I'm sure. So I'd love, again, to your level of comfort, to share with our listeners what's the most challenging thing that you've gone through in your life, and what do you recall having done to get through it?
Yeah. So, Adam, unfortunately for me, that's an easy one, and that was the diagnosis and death of my late wife. Um, you know, we she died 11 years ago, and when my boys were little, she was diagnosed with metastatic melanoma. And so, which, left to me as sort of the caregiver for everyone. The boys were 4 and 6 when she was diagnosed, and 6 and 8 when she died. And, something she came from a family, from women and grandmothers who'd lived almost to 100, like we always joked about how she would, outlive me by 50 years, because
Yeah.
I come from a family of people who don't live nearly as long. And so, um, that total, loss of one control over your world, the crashing in of everything you expected to happen, in life, um, was totally, overwhelming, disorienting, right, at times.
Mhm.
But but you can't stop living, right? I mean, you can't stop getting up every day. She had appointments, she had scans, she had, intensive medical, hospital-based medical care for a long time. The boys had to be in school, right? So what did I have to do? I had to focus on what could be done, what was possible
Mm.
that day. Well, that day that was possible to get the boys up, and as much as frustrating and difficult as it was, get them dressed, to get them to school, to later on to get them to the bus because they were in preschool. One of them was in preschool, one was in kindergarten when she was first diagnosed. At that point, as I said, I was making sure everything was happening for everybody. And, I would do all I could every day, with making sure everything that had to be done, which was mainly focusing on them and on her, was done. And at night, I would, ask someone to please, make this all get better, and that's,
Yeah.
all I could do. And so
Mm.
the only thing that kept me, and certainly I wish I would have in retrospect, you always think, oh, should have been stronger. I should have done this. I should have done that. Everyone saw me cry all the time back
Yeah.
then.
Yeah.
I mean, not in front of her, but especially after she died,
Sure.
but I feel like, um, every day was just about accomplishing what had to be accomplished that day
Mm.
and getting up and
Mm.
starting it all over again. And that's what, and her oncologist too was amazing. He was at Hopkins, what said to her too when she's first diagnosed, she's like, "Oh, what if it is a terminal illness? What if it is something that's going to kill me?" And his response was, "Well, you can't stop living now, right? I mean," he said,
Mm.
we'll deal with it, and we'll do what we can." And we did. We did everything we could, but unfortunately, she had an illness that there aren't a lot of treatment options for, and ultimately she succumbed to. But that's and since that time, and it's the profound knowledge it gives you about the depth of grief and the loss. I mean, we greatly underappreciate that in our world.
Mm.
We do not appreciate how impactful loss is on people, especially tragic loss. I
Mhm.
mean, losing someone who should never have been gone. So it's a long road to, feel like you can be okay, but you accept it, right? It doesn't,
Yeah.
you expand. One of the things she told me was, all she wanted was me to be, I could never stop loving her, but to expand my heart to love someone else too, not to,
Mhm.
and so you have to have those other experiences, even as painful it is to have lost something.
Yeah. Well, thank you for, first of all, being so open and vulnerable and willing to share. Deeply sorry for your wife's passing 11 years ago. And I can, sense obviously that still sits with you today, even though it's so long in the past. So thank you. And kudos to the courage that she had to be able to share that with you in her maybe dying moments that, hey, it's okay to love somebody else, because I'm sure that as you've progressed in life, have been able to take those words and give you some peace and knowing that you can find another partner, et cetera.
Right.
So I just a follow-up question on that, to again to your level of comfort in the moments after her passing, Dr. Pate, call it the first 6 months to 1 year. And the reason I'm asking this is because I'm hoping that if there was something tangible you did, our listeners can also do, because grief is something we all face, and loss.
Right.
Although I've not been exposed to tragic loss like that, I have friends who have been. What did you rely on beyond? I love your mindset of just, you got to keep living because that's powerful, win this moment type of thing.
Right.
But was there journaling, was there meditation, was there prayer, was there something else specific that you can look back on and say those things really helped get me through?
Yeah, my friends and family, I think, were the biggest things, right? I am and super close to my late wife's parents, and I probably talked to my mother-in-law, once or twice a day for several, months
Yeah.
to, for after, because she and I were, I think, the most devastated by, Lisa's loss. My late wife, Lisa, had insisted that I be remarried within 6 months. She said, which I
Wow,
told her
that's
was not crazy, which was crazy. But I did push myself to start. I started seeing someone later that year, and who I've been married. And we've been together for 10 years now, and married for 5 or see, it'll be 6 in September.
that's great.
And so, but those who I tried to create, around me, those I could turn to and be vulnerable with, right? There were a couple of my late wife's very close friends that I stayed and remained close to as well, that I would see and get out and have lunch with. And but it was hard to really allow myself to experience a lot of the grief, because so much of the responsibility for the boys was on me. And I was frankly spent a lot of those first few years just being exhausted, physically, emotionally exhausted. But I think finding time, for myself, meeting people, time just being on the phone with my mother-in-law for, 20 minutes a day and just talking about nothingness, and just exercise, getting back into doing some exercise, every day to have some stress relief. And that was really, I think, what helped me was just, again, the same thing that helped me get through it was focusing on what I could do each day and having some time for myself each day. Just, again, not complex, not difficult time, not time that costs money, but just, one of my favorite things still to do is to take the dog for a walk around the block in the afternoon, without headphones, without hearing any of them, just listening to the sounds of nature and the rustling of the leaves. And, to me, that's the kind of stuff that makes me feel better.
Yes. Yeah, that's great. Well, thank you again. We've got 4 minutes and there's one more question.
Oh, yeah, sure. We can answer.
So it looks like this came in maybe 10 minutes ago, so I don't know what topic we were on then, but listener asked, how do you recommend for people that have the "let me get this done" in quotes approach to schedule time for their worry when all they want to do is tackle the challenge at hand quickly so they can move on to the next thing?
Well, I think I think my recommendation for folks is you have to prioritize everything, including your worry time, your me time, your worry time, your family time, your work time, whatever it is. And so we all, many of us are much more driven to accomplish and sort of list and task oriented, right? So, and if you're one of those people, which I think you're sort of asking about now, then I would say you want to make sure you prioritize the things in your task in your world that have to be done, regardless if that's family or work. But also don't do that to the exclusion of taking care of yourself, right? Because again, we're not talking about a huge amount of time. Sometimes a 10-minute walk or a 5-minute phone call or 30 minutes of some stupid show that's mindless that you can watch is all you need. So for most of us, I think it's about really just being focused on what is the priority of that we don't add stress to ourselves, but also we give ourselves time to de-stress. You got to have both. There is no one in the world, I don't care who you are, the president, the biggest corporation leader, who doesn't set aside time for themselves, because those people are most successful at the highest level. I can promise you. People aren't bugging them all day, every day. Like they also set aside time for themselves.
Yes, that's great. No, I think it's certainly wonderfully answered from my vantage point. I don't see any comments from the listener reply, but I appreciate that context and thanks for the question to those tuning in. If there are any questions remaining, looks like we've got 2 minutes left. If I don't see any more questions pop through, we can close here. But before doing so, Dr. Pate, thank you so much. You were incredibly human today in terms of humanizing this conversation. I appreciated your vulnerability and deep insight shared in relation to the difficult conversations that I think so many of us want to avoid, the depressions, the suicides, the anxiety buzzwords that are out there in our world. So very, very grateful for you, and thanks for joining me.
Thanks, Adam. I really appreciate you taking the time, and good luck with everything.
Thank you so much. Have a great day, and I'll follow back up with you offline and send you a recording to this. But again, we'll close here. Thank you, Dr. Pate, and thank you all for being with us. Have a great day.
Bye-bye now.